Hello, everyone. My name is Eileen Greenberg, and today I'll be presenting a challenging women's health case I encountered during clinicals. This case involved a 21-year-old Hispanic female diagnosed with bacterial vaginosis with complicating factors that raised concern for possible trauma or assault. I'll walk through the clinical details, assessment findings, pathophysiology, differential diagnosis, treatment plan, and conclude with key takeaways. So, why was this case challenging? This case was particularly challenging for me as a nurse practitioner student because it involved possible interpersonal violence. The patient presented 10 days after a night of heavy partying with bruises she couldn't explain and memory loss surrounding the events. So, as a provider, it was difficult to navigate the clinical symptoms while holding space for the possibility of unreported assault. The emotional and ethical complexities made this case I won't forget. So, our patient in this case is MSO, a 21-year-old sexually active Hispanic female, presented with profuse vaginal itching, foul smelling discharge, and irritation. She noted these symptoms had worsened over the past few days. So, while she denied douching, she did report using regular soap and water and sometimes holding her urine. She had not visited an OBGYN before, and this was her first women's health complaint. So let's talk about the pathophysiology of bacterial vaginosis, or BV. Bacterial vaginosis is a condition caused by a shift in the vaginal microbiome. Normally, lactobacilli maintains the acidic pH by producing hydrogen peroxide. In BV, these protective bacteria are replaced by anaerobic species like Gardnerella vaginalis and others. These organisms form a biofilm that adhere to the vaginal epithelium, disrupting the ecosystem and leading to symptoms like odor and discharge. So, what were the clinical findings in this case? On exam, the patient had homogeneous off white discharge with a strong fishy odor and notable vulvovaginal erythema and irritation. No lesions or ulcerations were found. Her vital signs were normal. Psychosocially, she reported good school performance, used alcohol occasionally, but reports no contraceptive use. A sugar swab was collected and returned positive for bacterial vaginosis. What are our cultural and age factors? Culturally, the patient identified as a Hispanic and practiced Catholicism, which may influence health seeking behaviors and attitudes towards sexual health. At age 21, she was just beginning to access women's health services. Language support was provided via an on site Spanish medical interpreter, which was essential for establishing trust and understanding. So, what are our differential diagnoses in this case? Several conditions were considered. We have our primary diagnosis, of course, which is BV, which was supported by the discharge characteristics and odor. Then we have trichomoniasis, which we ruled out due to the lack of frothy discharge, and there were no motile organisms found on wet mount. Then we have candidiasis. The patient reported itching, but the discharge wasn't cottage cheese like, so we ruled that out. Then we have chlamydia and gonorrhea, which is possible given the patient's sexual activity, but less likely due to the absence of dysuria or bleeding. And labs were collected just to rule out STI. So, what is our treatment plan for our patient? Pharmacologically, we prescribed the patient with metronidazole, 500 milligram dose, to be taken twice a day for 7 days. Though studies showed that tinidazole and ornidazole have higher cure rates, metronidazole remains the first line due to accessibility of the medication. The patient was advised not to drink alcohol during and 72 hours after treatment to avoid disulfiram like reactions. Non pharmacologically, we recommended to the patient to avoid sexual activity until symptoms were resolved, refraining from douching or using intravaginal products, and switching to cotton underwear. No referrals were made at this stage, but close follow up was planned via telehealth once the labs are resulted. Education and counseling were given to the patient, which focused on medication adherence and alcohol avoidance, hygiene practices such as avoiding soap internally and no douching, safe sex practices by using condoms consistently, partner discussion, especially on the importance of partner testing if STI is suspected. We also reinforced that the patient should feel safe discussing any concerns about memory loss or trauma and that resources are available if needed. So, what are my reflections on this case? In summary, this case reinforced how clinical practice often blends medical care with psychosocial complexity. While BV is a common and treatable condition, the context of possible unreported assault added layers of sensitivity and required thoughtful, trauma informed care. As a student, it was difficult not knowing how far to probe or whether to involve a social worker without the patient's disclosure. I learned the importance of documenting clearly, maintaining a non judgmental demeanor, and creating a safe space for disclosure. These references were used to guide the clinical approach and treatment decisions. This concludes my presentation. Thank you, and I hope you enjoyed it.